cell phone technology has developed so fast and so good in our, to be able to help us out, that now we're able to actually really use this technology. And what I mean with that is not only be able to see each other, like FaceTime, or send files back and forth and look at each other, but actually on a medical level, be able to diagnose, be able to look at patients, be able to screen patients, be able to run different tests on patients live from distance. So what we've created here is we set out a bunch of years ago to say, okay, let's come from it from a medical standpoint, from a hospital standpoint. Let's create a virtual hospital. How do we do this? Well, how does it need to look? How does it need to feel? What does it need to do? So from that standpoint, we stood and we said, okay, it needs to be as if the specialist was sitting in his office with the patient. And he would have to be able to do every test he did in his office from distance, the same or better. So we see that, we all know about technology, how fast it's going, but there's different levels and there's a lot of noise. So there's a lot of stuff we're hearing. And a lot of us say, yeah, but that's already done, I'm hearing that. And an iPhone watch can do almost everything. Soon you'll be able to have an iPhone watch that just diagnoses you and tells you, hey, you're sick or you're not sick, and your temperature, blood pressure, everything. Well, that level of care is not medical level. The FDA set a separate standard for that, and those are sporting activity meters, that level. For a physician to be able to diagnose off of componentry, they need to be FDA approved or European spec to say that, okay, a physician is allowed to take this measurement and be able to base his diagnosis, his assessment off of this measurement. And that means with temperature readings, with blood pressure, with blood sugar, with anything you do, ECG, whatever he's doing. And so from distance, it's even the same. So it's digitized. And we're going to talk about digital stethoscopes, not this anymore. If you see a picture with a physician with one of these, he's old, he's antique, or he's like out of, they don't do that anymore. Now you're going to see digital, because that's where we're going. They're much more accurate, they're quicker, they're able to be done in distance, everything. So the old paradigm is changing quickly, also for the physician. So what we're going to discuss today is how this came about and what are the requirements, because one of the things that Europe and everyone's freaking out about is security. Even with introduction of e-files, electronic patient files, everyone's like, security, okay. So there's been standards formed, and the standards in the United States are called HIPAA, H-I-P-A-A. In Europe, they've just now come with standards also for telemedicine. And they're called the European standards, but it's based off the HIPAA. US was already busy a long while with this. So we're going to look at how that incorporates, how that makes it different. So it's not as easy as saying, well, I can just Skype with a patient. No, you can't. It's illegal. Okay, now I know Aruba we can still like play around with that, but in reality, around the world, that's not legal, because you're setting the information of patients to anyone. It's open for anyone to grab. My son is a computer science major. He can grab any information, anywhere. So I know how vulnerable these regular things we use are. Very vulnerable. So we need to really look at, okay, what does that mean, and what does that mean for the cloud? So we're going to go through a little thing. We've set up this company, like I said, with the vision of, okay, this needs to be function as a hospital, needs to function as a clinic. It needs to basically give access to care, unfiltered, unobstructed, anywhere you are. Are you in the middle of the ocean? Are you in the jungle? Are you in Africa? In areas where they don't have Wi-Fi? Because some of the countries in Africa have super Wi-Fi. They're just not using it. They don't know how to use it, but so there's different areas. Every area is different. And so how do we use this? Okay, how do we secure it? How do we use it? And as physicians, as pharmacists, as nurses, how do we take advantage of this? And how is this gonna change completely the way we work? Because it's transforming how we do it, the way we work, and what we do, and how fast we can do it. But the key idea is that people that haven't had access before now have access to specialists, have access to information, have access to anything they need. And one of the reasons we dove into this, that I had a thing for this at the end of my stint as minister here, is because this is one of the biggest problems in the islands. We're shipping people out at $1 million a month, and we're all over the place trying to get specialists, not get specialists, shipping people out, seeing what's cheaper, what's this, the whole time. And islands are always gonna have this problem because we don't have enough volume, so you can't get certain specialists to do their specialty because they'll go in default of their license because they're not seeing enough volume. So you have to ship certain cases out. You have to ship the high-end cases out. And if you're trying to do like a real advanced cardiology center of cardiac surgery, then you need backup teams for when stuff goes really wrong. Those backup teams require almost a whole hospital. So there's things you can and things you can't do on islands. And this is our dilemma. So we're always like looking, okay, where can we share specialists? How can we do this? Well, this frees that up. And it frees it up for a lot of countries around the world. We've interviewed with 125 countries to look at what problems they have. These are countries that are super advanced, these are countries that are third world, and everything in the middle. Islands, big countries, they all have the same issues. One of our biggest projects right now is in one of the most advanced countries in medicine, which is Sweden. This is one of the biggest projects we're having, is with Sweden. And you think Sweden's like advanced. They're like in Europe considered the guys. Well, yeah, they are, and this is why. They're always on the forefront on using the best technology. So why will Sweden, and we'll go into it, why Sweden wants this, and what settings they're using it for. Okay, so if we're looking at the virtual health solution, we're looking at a cloud that is HIPAA compliant, equipment that's FDA approved, medical equipment that can connect to office buildings, virtual cases, airline terminals, airlines, doctor's offices. We're connecting everything. One of the biggest projects we're doing is with an airline. Say, okay, why would that be? Well, guess what? People that fly around the world, passengers, want to have a physician in their language and their culture, wherever they are. And now, we can get that right on here with an app. So wherever they fly, 24 hours a day, they can connect to their physician. They can connect to a physician. We can connect and have their medical dossier sent immediately, or pieces of it. They can be part of a co-consult when they're in a different country. This is what happens. People fly around all over the place. Business travelers, expats, they're all over. They're living everywhere. But no one trusts a physician. It's natural. That's not from their country, doesn't speak their language, because they feel they can't explain themselves the same way. The cultural difference sometimes is also a block. So people prefer to have their own physician. That's right. I mean, we did a very small study in Holland where there's a lot of expats that live in Amsterdam and everywhere. Listen, Belgium's pretty close to Holland. Germany, pretty close to Holland. France. These French, Belgians, Germans, and on and on and on. They'll wait to take the train home to go see a physician before they see it in Holland. Meanwhile, you're going to Holland, has good physicians. They got the best hospitals. What do you know? They just don't, it's not the same system, it's not the same whatever. You know, the medicines don't look the same sometimes, different names, and the physician doesn't understand them. So even that close to each other, patients just prefer their own physician. And we're seeing it with the communities within Holland and within these other places. So this is one of the things we're doing. So anyway, when we can connect all this, all of a sudden it opens up. It opens up a world where we can move stuff. You know, for pharmacies, there are countries that will have digitized everything. So your prescription is digitized and it gets delivered to your home. And certain countries say, okay, for the working force, that's what they want. Because they don't want the working force to leave and go have to sit in a pharmacy or sit in a doctor's office half a day to wait for an appointment and then wait for their prescription. They want that resolved. So these are the solutions coming in. So we have to redefine what we do and how we work with this. So I already went through a little bit of this, but the key points to the cloud system, this is pretty, at the scaffolding, it's just sharp, or it looks like. Is there a thing?
This is the
Or oh yeah, is there a? It's not focused.
You can see it.
Is that it? Doing focus point.
I haven't found it yet.
Let me just speak it.
Yep. I don't know. Really know.
No, I don't dare to do this. Okay, so I'll just like here we got the cloud base with a multi-point. See, with a multi-point conferencing system, phone bridge embedded. It's a little bit technical, but this is where the stuff happens. So you have in that, for the physician, he has his tools where he can send invitation emails that automatically click into the cloud. And so what we've created is offices in the cloud. So a physician or specialist or nurse can rent an office in the cloud. The patient meets him in the office just like they would in a real office. It's in the cloud, from their computer, from their iPad, from whatever. And the experience is the same. So the physician gets, your patients are waiting for you, and the patient sits there and says, gets on their screen, your physician will be with you in a second. And then they connect. So if there isn't anyone helping, if there isn't a nurse there, if there isn't a technical person that's helping the patient. So all the stuff that we do, medical images, sounds, data, everything that we transmit is FDA approved. Needs to be, because the quality needs to be in a certain point. So even if you know, like we're doing now, hey, I'll just email this or copy this file, send it, or I'll send an MRI or CT scan over to the other side. It's not FDA approved. It can come to the other side. It might not have the specific quality that you need to be able to read it. The physician on the other side. So this ensures that the system is a medical FDA system. So the cloud becomes a medical tool. It's not just a communication system. And so the equipment that goes with it. We have remote monitoring, more than 16 devices. So what we're doing here is making the possibility of making a hospital bed in your home. Basically, we can monitor you 24/7 at home. Lighter, but kind of the same as they would in the hospital. And this is remotely, so that all of a sudden the hospital with 3,000 beds can be managing 30,000 beds, because they're also managing the home beds. So people can be sent home earlier, they can be monitored longer, and it's less expensive. chronic disease patients that are questionable, they can also be monitored. So this equipment is really for the home. It's small, it's portable, it does it automatically, and you've probably seen parts of it. The medical triage that goes with this is the back of the house. This is super important because this is where the calls come in. This is where they decide who this patient meets, where, what language, the whole thing. Everything gets prepped here so that the physician and patient feel like all they did was press one button and they got connected. So that needs to happen, because if there's work, and we see it, we have projects in Holland too, if there's work for the physician or the nurse or whatever, and it's a bit technical, they're not gonna do it. So it needs to be handled. So these are an important part. The cross-platform system, accessible to everything you use, PC, Linux, doesn't matter. It needs to have that because everyone is using different systems. Third-party integration, same thing. So this platform really it doesn't matter what kind of APD or e-file system you have, it'll read it, it'll send it as soon as you open it. Because even if we talk about our project in Sweden or in Holland, in Sweden there's about 20 different e-file systems. Everyone has their e-file system. So if you're gonna base it on that, you're already in trouble. So this is how it kind of looks like. Now it's obviously clearer than you see here. This thing is out of focus a little bit, but right here, so this is the way the physician sees it, and you can have up to 6, 7 people at the same time. So you can do co-consults with teams on the patient, you can bring in, other specialists, you can bring in other people that are involved in the case, and together, handle the case from distance. And really, here is where you can let them have insight to what you're seeing, your computer. You can send videos that pertain to this. So if you have a video explaining what the patient needs to do, how the patient needs to take their med, that can be sent, small bits. Invitations can be sent. You can do polling to see after the call how the patient felt, what could go better, what did they have to wait too long, was it too short, whatever. If you have a questionnaire that could be prepped in advance. Invites get sent. So a patient gets, for a return visit, the patient will get an email. The email's already embedded, so all they have to do is, okay, Monday, 10 o'clock, I go on my email, I press the link, and I'm there. And I'm waiting in the waiting room. My physician will show up. They'll tell me when he shows up. So all these and more. So you have a whiteboard, and we'll look at that too. You'll have all the tools there to really pull up files, send files, show files, do co-consults with other physicians, everything. For nurses, same thing. When they're working with patients and they're connecting to their house doctor to let them see what's happening, to go live in a consult with the patient, so they're at home with the patient in bed. It's a diabetic and they're looking, the wound doesn't look good. Okay, let me go, turn it on. House doctor comes online, sees it, says, okay, let me get a closer look. Okay, we go with the scope, look at it, and I'll show you some of this stuff in a bit. And the house doctor, with the extended arm, can then make decisions right there and then, change the prescription, no, they don't have to come in, just let it go. So a lot can be done, and a lot of time can be saved. So these are some of the things that we do. So, like I said before, in the center, we got the triage hospitals. And these guys really, these teams coordinate everything. So from pharmacies to nurses to home health, hospitals, intensivists, visits, everything. There is where it gets done. And they're actually connecting, it's all digitized. You can also, they can also plan in the physicians. And we're talking, managing, tens of thousands of physicians in one area, from one country, from one city to the next. We work with different hospital groups. So you have European physicians, you have American physicians, you have, all countries, all over the world. We're working with Saudi Arabia also. So it's a plethora of people that we're connecting across the board. So in the app, this is what you see. The patient gets the app, or the physician also, the people that work with the system. And depending on what you have, if you have Apple, it's Apple Store. If you got anything else, it's the Google. play, but you don't need the app. The app is something that we use to get onto the system very quickly and very easily. If we're looking at the cases, we have cases that specifically connect to the cloud so that we can go from level, what we call, when we are able to see the patient or the other physician or the second opinion or whatever we're doing. If we're able to see, transfer files, we're looking at a level 1 to 2. What we do here is we go all the way to level 5, which means we do diagnostics. And so with this case, we get to, and this case is smaller than this. So this case is really like a small case that we use as a nurse's case. We use it as a case that goes on the airplanes, because the airplanes will have these now, where they're not asking anymore, is there a doctor on board? They have their doctors. Because when you ask, and it's happened to anyone that's flown, is there a doctor on board? And then people raise their hands. You don't know if they're a real doctor, where they studied, what their credentials are, if they can even speak the language of the patient that's like dying on board. And they're gonna have to assess the patient and tell the pilot, land the plane for $1 million minimum. Or, no, go ahead, and then the patient dies. So these, airlines are getting a little bit like, okay, we need to handle this in a different way. So these are able to connect through the Wi-Fi, and these are just for the long flights on the wide body jets. They're able to connect down to the physicians that are appointed by the airline so that they can do the assessment. And the, two pursers per flight, the top guys, get trained on each flight to be able to do this. And it's very simple. So we have a digital stethoscope, multi-purpose camera, ears, eyes, nose, throat, and dermatoscope. Vital sign monitor, pulse oximetry, 8-lead EKG, and spirometry. And this is one of the setups we have that's a general setup. Everything here is Bluetooth based, except for the scope and for the stethoscope and the general scope. Those are hardwired, but the rest is Bluetooth. So when we're measuring it, it's sending the data straight through to the physician on the other side. So it's a very compact kit. It's only 5 kilos, 10 pounds, 4.8 kilos, and you're able to travel with it. So we're able to put a chip in it for nurses that are, heading out to, rural areas or areas where there's no physicians, no hospitals, and they can connect to the hospital, they can connect to physicians, everything, and connect the patient and do what they need to do. So this is one of the units that we're using. This one is the units that we're using, and this is a version of it. So every unit is customized. This is something that we're using right now in Holland. It's like a 32-inch curved screen we have there. High-end camera that follows the patient and the physician. And then you have it set up like, this one's set up like an urgent care center. So this unit here is an urgent care center. You can place this anywhere, connect it up, and have hospitals or clinics connect to it and treat patients. So it can work like a complete center. The mobile carts right now are used in Holland for under half a lane, which means that a house doctor can connect to specialists and then get a diagnosis from the specialist. And 80% of the cases, the specialist can decide and say, you know what, this is the prescription, this is the protocol, but you go ahead and do it. Patient doesn't have to come to me, you see it through the end. Insurance companies love it, it costs less in the end, and a lot of times, not every time, like I said, 20% need to go to specialists, but a lot of them, in consult with the GP or the house doctor, they can just finish off. And so the specialist is able to see really what he needs to be seeing, and less of these cases that he kind of says, the house doctor could have also done this. It wasn't, maybe he needs my advice a little bit or my input, but that's it. So in Holland, that's one of the things that we're working on. In Sweden, we're using this in schools, so no no more school nurses, no more physicians in the schools. And the schools are connected to children's hospitals. Specifically in Sweden, this is happening. And these guys are very advanced. This hospital is a neurology hospital and goes all the way to neurosurgery. And what they do there, they specialize in everything from ADD, ADHD, so the low-level stuff, to learning disabilities, to any issues kids have, all the way to brain surgery. And what they want to do is screen the kids early to see if there's learning disabilities, if there's issues, they can attack it right away and start working with these kids. And so it has a couple of purposes. One is screening, one is working with the kids. But the most important thing is that there's only one center in Sweden, in Stockholm, that does this. Sweden's pretty large, so people have to drive a long way to get there with their kids. And a lot of these treatments take multiple treatments, right? So you're busy with your child for a year, maybe 2 years, and trying to get them, to get over their issues. So what happens in the clinic is that parents will come, 5 times, 10 times, maybe a little more, and then it stops because it's too much work. They've got other kids. They got to go sit there for an hour. They got to drive all this way. So as good as they are, they can't perform the treatment. So they need to find a new way. This is the new way. This is how they do it. So this is one of the big reasons. And the other reason is just being able to catch the kids early. We're using systems in other countries for elderly, chronic patients, to be able to monitor them, to be able to manage them better. So if you have a group of chronic patients, like you guys have here at Imsan, you got diabetes, okay? Your nephrologist doesn't have to keep driving back and forth. He can be in the hospital over there, talking and assessing with his team over here on patients, without having to drive the whole way. This is time lost. So he could be working there in his practice, he could be assisting patients here, assisting the nurses here, without having to move back and forth. And he can assist the other islands too, if needed. So it's not only here, but if Curacao needs him, if Bonaire needs him, if Statia, Saba, these islands all have issues. They all have Tokorten, they all have issues with not having the specialist. So this is where we could move. The ability to be able to have specialists look at patients from Holland, from Colombia, from pre-assessment. And when they come back from surgery, to do the aftercare. Right now, there's no aftercare. Who has to do the aftercare? The local doctor. They don't really want to do that. And the patient, also would rather have the physician that operated him see them a couple times a month, just to make sure everything is going right, the communication and everything. And also in the assessment before the patients go to Colombia or go to Holland or wherever we're sending them, that the physician really knows what he's getting. Because a lot of mistakes are made. It's not mistakes, it's just not enough information, where when the patient gets there or when the physician gets there, the patient is a different patient. It's not what he came there for. It's not even his specialty. It might be another specialist they needed, but they thought it was him. And this happens with the VU in Bonaire. We have cases. It happens in Colombia where the patient goes and then they realize this is a different case. But if they could have seen or co-consulted with the patient beforehand, this wouldn't have happened. So these are things where we could save a lot of money, save a lot of time, save a lot of headaches. With second opinions, we know in the best hospitals in the world, United States, Europe, 30% misdiagnosis. This is just fact. It's not they're bad, or this is what happens. And so if you have a serious condition, if you get diagnosed with a serious condition, one of the first things you should do is get a second opinion. Okay, so it's easy. Usually people want to get a second opinion from somewhere else. Okay, I need a second opinion, but I'm not going to go to the same team. I want another team to look at me and say, okay, is it the same? Yeah, it's the same. Okay, then we go ahead. If it's not, I might need a third opinion to verify either number 1 or number 2. These are real things that people have needs. You know, in Europe, the second opinion gets paid for. There's no questions. It's just like, yeah, no problem, you should have it. So it's a thing more and more that we need to be looking at. So when we're using the otoscope, this is what you get. And it's not a sharp picture, but it's really sharp. So what the equipment is able to do, it works on 3G, 4G, Wi-Fi, even satellite. Satellite is less preferable because it's more expensive, it's more complex, but it can, if needed. And what it does, it's everything that gets sent, so it's all FDA approved, so the images, sounds, data, everything. So when it does an image like this, it goes over it 7 to 10 times before it gets sent. So you get a super clear picture of what you're seeing, and it's live. So you're seeing it live, you press a button, it's a picture. So the physician can really look at it, and it's for dermatology, it's for ears, eyes, nose, throat, it's for anything. We're doing echo, we're doing whatever we're doing with the equipment, this is what you're gonna expect. So if you're looking at, this is an example of an ECG, live, so you can do stress tests on patients, you can do the ECG, it's a 12 lead, Welch Allen, you're all used to it, except it's a special one for use in telemedicine. And then the whiteboard for patients. You want to illustrate where the issue is. So the patient's looking at the screen, looking at the physician, and looking at their own file at the same time. So what we've seen is that the patients adhere to their protocol longer, they understand what they're taking better, they actually have a better visit than in reality a lot of times. And this is the first question I get asked everywhere. It's like, yeah, but don't you need to, you know, our population likes to be touched. You know, you need to see a physician, touch him, you know, whatever. I said, okay, when's the last time a physician touched? Except for if you're going in for a prostate exam. Okay, you're usually sitting across the table with your file, looking at your blood panel, looking at the tests that have come in, looking at this, and they're looking at it, you're not even looking at it. You're on the other side, stressed out, waiting for the result. Maybe they'll show you, you know? So with this system, when you're looking at first of all, you're in a comfortable environment, you're looking at the physician talking to, you're seeing the image, you're seeing the issue, you're seeing your own file, you're seeing the results, and patients just get more involved. No matter what level of education they have. I mean, this is tested in Africa. This is tested in, you know, very poor countries. The very wealthy countries. It's the same. The experience is the same for them. And so it becomes very valuable what we can do with this. If we're looking at what the benefits are, and these have been studied. I mean, the most obvious, transportation, time. You know, a physician that still visits patients, if you have to visit a patient, if you have to go make your rounds, time is gone. Time where you could be seeing other patients. It's gone. A half a day could go. You know, when we have the physicians fly in from to Bonaire, from the VU, they're missing a whole day. And then when they go back, they miss another day. And when they're there, the patients that they see are not always the right patients. So they're missing out. I mean, it's nice, you know, especially in the winter time to be coming, but we need to be able to do it more efficiently, more effectively. And with this, we can do that. 24 hours a day access. You know, what we see now is that our hospital is filled with people. All the emergency centers are filled with people that are not supposed to be there. If they would have access to a nurse practitioner, access to a physician on call that they could go in and see, then most of the issues would be resolved. And we'd have the real patients that we need at the hospital and less complaints. Because if you come in with something and they triage you and they give you a green card or whatever, you're gonna be waiting the whole day there because you're last priority. And then you think the service is bad. No, there's people that come in with real stuff that need to be seen before you. This is what the triage does. Okay, these are critical patients. They go before you, even if you came first. So all these patients, in the meantime, could be seeing someone else and relieving that area, relieving the hospital, relieving the waiting time. So this is where this becomes useful. Traveling patients, connecting to their physicians. When you travel and you're stuck in a country and you don't know, even if you know the language, culture is different. They don't know you. An emergency happens. You go, even if for tourists here, you go into the clinics. They look at your insurance. They see, oh, they know insurance. So they go, okay, so this one we can bill for about $40,000. And then they start running all kinds of tests. Because they don't know your blood type, they don't know what allergies you have, they don't know, they don't have your file. They don't even know what medicines you're taking because you can't remember exactly what you're taking. Okay, so they'll go through a battery of tests and then add some more tests to it. And insurance companies and people that are on the other side paying for this have this problem. They have it with expats that are in different countries. These tests get done for nothing, but they have to be paid. So if you have your physician there, one, they have your file. Two, they can co-consult and they can direct what needs to be done and what does not need to be done. And you have a much more efficient for the patient and for the physician on the other side, for the clinic on the other side. Because they know, okay, this physician, these patients, this is their medication group. This is what they have. These are their comorbidities. This is what they cannot take to mix in with the group. They don't have to go guessworking. So it's much more efficient. And these are systems that are available right now that we could use for this. So these are numbers that in the US they've studied this, and it's worldwide, same thing. Retention rate by patients, transportation expenses, the physician's efficiency, how many patients he could be seeing, how he's managing his patients, how he's managing his chronic patients, because chronic patients is where it's at. I mean, if you want to talk about where the spending is happening for us at VA, for worldwide in all insurances, chronic disease. That's why the WHO has chronic disease as number one. That's where the expenses are. So if we can manage that better, we can save so much. If we can make our hospitals more efficient, if we can make our specialists more efficient, if they can see more patients, then we have less waiting time. If we can, make the process work better. If nurses can do more because they're the extended arm of their house doctor. And if house doctors can do more because they're the extended arm of specialists. And specialists can do more because they can co-consult with other specialists and other universities. Then all of a sudden, you're upgrading your level of care, you're upgrading your reach, you're upgrading the accessibility of care in your country without putting one extra stone, without hiring one extra physician. You're already doing this. So countries are looking at this very intensely, both on the side of where they don't have physicians and on the side where they do have. And it's saying, listen, we need to work more efficiently. These specialists that we have need to be able to see more patients because we're paying all this money to have these specialty centers. And then only people from 30 miles away come. What about the rest? What about the rest? How do we get this knowledge to the rest that doesn't have it? So this is what we're looking at. These are the solutions we're doing. And again, for the islands, this is it. I mean, this is really where you go next. One of the things that that we're seeing, I think initially the project that we looked at to start with Baptist Health South Florida was in that, so that we have a cancer center here, so that their physicians can work with systems like this and look at patients, not only our patients, but also Baptist Health, as you know, is very well known in Latin America and the Caribbean. So a lot of these patients want to go there, but not all can go because not everyone has visas to get into the United States. So they saw Aruba as, we can put a dependance there. Those patients could go there, and we could see them there. You don't have to go into the US. And we can give them the assessment with the local specialist via us as a co-consult. So these are things we need to be thinking about. How do we do this? How do we make it more efficiently? How do we create real, medical tourism? If we're working with projects in Turkey. Turkey right now has, per year, I think it's 700,000 medical tourists coming. Just for treatment, from Europe, everywhere. Why? It's efficient, it's cheap, their level of care is high. So people go for everything. And so they're also looking at, okay, but how do we treat this population better? How do we do the aftercare? How do we do the pre-care? How do we introduce patients to the physicians they're gonna see so they don't have to come blind? Okay, I'm gonna go to Acıbadem Hospital, which is one of the well-known Turkish hospitals groups, but I don't know who I'm gonna see. I'm just gonna fly there. Patients don't like that. They like to meet their physician, they like to meet and have an assessment, how they feel about the physician that's gonna operate on them. So in that sense, you're able to do much more. And then if they know they can get the aftercare, it's a done deal. So in medical tourism, this is gonna play a big role. For us, medical tourism will never be a big role, but it can be a little role. For us, the most important part is gonna be, how do we get access to all the specialists we need? How do we get access to quality care? And how do we give everyone access to it? And this is one of these solutions. How do we work together as islands? Because Curacao might have specialists that we don't have. They're getting done with their new hospital. Bonaire is looking at connecting to other islands. And Bonaire has also the responsibility of the other best islands, which is Ceiba and St. Eustatius, who have just a general practitioner there. That's it, nothing else. So they're looking at, okay, how do we resolve this? We can't keep flying specialists down. It's too expensive, and it's not efficient. How do we do this? How do we work together? And I think first you work locally before you go out. So you have to try to resolve it between the islands. If you can't do it there, you go a little further. Guadeloupe, Colombia. If you can't resolve it there, or you don't want to, then you go Holland, the US, you go further out. But you gotta keep it there. But you have to have those systems that are able to do this, that are able to do the assessment, that are able to do diagnostics, that are able to, allow you to co-consult. And the system needs to be safe internationally, meaning that you're HIPAA compliant. The data cannot be corrupted. The data is, all the data going, all the voice going, everything, images going, are all encrypted. Nothing is not encrypted. So everything that moves on this line is like a bank. And all the sessions get stored for 2 years. So not only you have your e-file, but the actual session, the video session, gets stored. So the physician can call it back and look at it. What was I saying to this patient? Did they not understand me? What went wrong? Or they can assess back, look back and look at the session and say, okay, how do I communicate this better? And every time get better at how they're doing it. So these are options. I think the ACV is looking into this too. And they're looking at, okay, where do we put it in? How do we, if we do this? One of the things I told them, I said, Imsan is a for sure thing. I think with the diabetes center being there, key to doing this. And with everything else happening in Imsan, it would be a key place to, as one of these places where you definitely do it. The other definite would be all the patients that go into Colombia to get pre-checks before they go, co-consults with the physicians, physician to physician, and then when they come back to be able to do post-care, the aftercare. So I think those are, and there's much more. Elderly, in Sweden we're doing a project with elderly, it's phenomenal. We're working with a company together that developed this watch because they've seen in Sweden that patients don't like to wear I'm sick gadgets. You've seen that thing in the States. I've fallen, I can't get up. It's this big thing they wear here, this button. Okay, patients, elderly don't want to wear that. Okay, they don't want to wear like I'm sick, I need this button to survive. They don't want to do that. So what they've developed there is just a nice watch, different models, whatever you can get. but it's digital, and it calibrates the way you move. So it works like a watch too, but it's connected to triage center, to the data center, and it gives continuous signals on how the patient's moving. So people that are getting above 50, 60, wear this watch, and it does algorithms to let it know that, so it has some AI in it, artificial intelligence, to be able to calculate, okay, this patient walks this way, they get up this way, they have this much tremors, or they don't. And so what it does, it starts calculating when that changes. And it gives us an exact reading that, 1, this patient is having a stroke. 2, this patient is having a heart attack. This patient has just fallen. So it's giving us specific information based on movement type, 3-dimensional, on how to react. And we get the red flag, we then call the people, the call goes into the people that are attending that physician or that are you. So now you have patients that are, 60 plus, that are feeling confident that they can live independently way longer. That's what these countries want. They want their population to be able to feel safe, that they can live way longer on their own. They're being monitored. We can monitor the blood sugar, whatever's needed, but that they can be living independently. And that's where it's moving towards. When we're talking about homes that come in, so if you have elderly home setups where they're living independently or they're living with physicians, you have one of these units in there, and any specialist can come in and out and look at patients. So all you need there is the nurses to be able to work it. They bring the patient, I need a dermatologist. Okay, can you look at this patient? Or I need a geriatric, specialist. Okay, can you look at this? This is what's happening, what should we do? So they can assess it. These physicians, physical therapists, movement specialists don't have to always be moving from place to place to look at the patients. So I'm gonna keep it to there because I wanna have some room for questions, answers. I know there's questions coming up in the back.